Hello, I am Edouard Demeire, professor at the CETIP Institute, located here on the INSEAD campus in Fontainebleau, and also Cell for Pharma faculty member. Today, I would like to share with you the concepts of the patient flow and the patient journey. How do these two concepts differ? How are they used in developing the medical, access, and commercial strategy and tactics? Here is a very classic example of a patient flow. This particular disease has a prevalence of 1%, which means that out of a country's population of 100 million, 1 million patients are affected by this particular disease. Half of these are diagnosed, which is 500,000 patients. Two-thirds of these are drug treated, which is 336,000. 20% of the patients are receiving an injectable drug X, which means the compliance is relatively high, 90%, 60,000 patients, hence being properly treated by this particular treatment option. 80% of the patients, however, receive the oral drug Y, and here compliance is a much bigger problem with only half of the patients complying, or 135,000 patients. The nice thing about developing a patient flow is that you can immediately identify some key leverage points. For example, key leverage point 1 would aim to increase the diagnostic rate through, for example, medical disease awareness programs. Key leverage point 2 would be about treating more patients rather than not treating them, which could be induced with, for example, health economic analysis. Key leverage point 3 would entail trying to get the patients who are today on drug treatments which are injectable onto an oral solution, which I guess most patients will tend to prefer and which will also use less hospital resources. The challenge with the oral drug is that half of the patients are not complying, so key leverage point 4 would entail developing a patient adherence program. In this particular case, the patient journey is going to be very similar to the patient flow. The first step being diagnosis, the second step being the treatment decision, the third step then being the choice of the drug that will be used, and the final step being compliance. The brand strategy will then entail making two choices. The first choice is where to play. Which of these key leverage points we have just seen should be addressed by the company? For example, if you are working with an injectable drug, you may not want to develop the diagnostic in this disease area, as this would mainly benefit the dominant oral drug. And the second question will be, for each of the key leverage points that you have addressed, the question as to how you will win, which entails developing a positioning statement, which clinical data will be required to support that, which messages should be communicated, which will ultimately allow that the patients, the HCPs, and the payers, and also the brand to win. Our previous example was an example which was quite important in the days of primary care. In that case, the patient flows and the patient journeys were very similar, so it didn't make that much sense to add a patient journey. Here is a slightly more complex situation where the notion of patient flow changes a little bit. Take, for example, this particular cancer type, cancer Z. 40,000 patients will develop this particular type of cancer during 1 year. That's what we call the incidence. Now, half of these patients will be resectable. That means that surgery will be beneficial for these particular patients. Half of these patients have a disease which has progressed beyond the state that surgery would be beneficial, so they will receive drug therapy. Now, what may happen is that these patients will overexpress or not overexpress a particular biomarker. So 10,000 patients would have the wild type, 10,000 patients would be muted. In this particular case, the wild type patients would first be treated with chemo A and biological X, which would be a targeted therapy. And then afterwards, in the second line, after they have relapsed, chemo will be changed to chemo B, and the biological will also be changed. In the case of the mutant patient, it may be that the first line therapy of choice will be chemo A and biological Y, and the second line will alternate the chemo, but the biological may stay the same. The benefit of the patient flow here is not so much to show the progression of the patients through the system, but more to quantify the various patient potentials in each of the different disease states. Here is the patient journey in this particular cancer type, Cancer Z, and this patient journey will be quite insightful. First, the patient will be sent by the primary care physician to the oncologist, who will then request some X-ray, some surgeon, some pathologist to perform an X-ray, to assess the resectability of the patient, and to perform also a tissue staining. The next step will then be that after there is a positive cancer diagnosis, and after it has been determined that the patient is non-resectable, where the oncologist will request a certain number of biomarker tissue tests from the pathologists. The next step is that the oncologist will be waiting impatiently for the biomarker test result in order to determine the treatment of choice. The biomarker status and maybe also the payer guidelines will determine the choice of therapy here. Then the patient will be in remission, will eventually relapse, and then the prescriber will assess performance status, the patient's willingness to fight, and the payer willingness to pay in order to make a prescription decision for the second-line therapy. The benefit of this patient journey is here to understand the various stages that the patient goes through, the potential bottlenecks, and also all of the stakeholders involved in this particular patient's journey through their particular disease. Having then understood from the patient journey which are the crucial stakeholders, we can then start analyzing each of these different stakeholders' beliefs and behaviors. For example, the primary care physician has difficulties in diagnosing the cancer, and hence their behavior will be to refer the patient to a specialist often too late for resection and possible cure. The pathologist, for example, finds biomarker testing very interesting, but rather complex to perform, and their lab needs to, of course, remain very productive. So their behavior will be to train only a few of their highly specialized lab technicians to perform this biomarker test, to interpret it, and they may then decide to batch the tissue tests so that for the oncologist, some of the test results will actually be a little bit delayed. Surgeons will have to extract some tissue to be able to perform this particular biomarker test. And they're always worried of extracting too much tissue, which could induce bleeding. So depending on how easy it is to do, for example, in lung cancer, it's not always very easy. They may sometimes extract insufficient tissue tests to perform 3 different biomarker tests. In lung cancer, we now have EGFR testing. We also have PD-1 testing, and we have ALK testing that are relevant. Payers, for example, they believe that targeted therapies offer a guaranteed response and hence are very cost-effective, whereas they may believe that non-targeted therapies will actually not offer that particular benefit. So they may be willing to fund a biomarker test and a targeted therapy, but less willing to fund a drug which is for all patients. The benefit here is to understand how each of the stakeholders play a particular role in the step of the journey, what their beliefs are, and which beliefs will be addressed by which types of tactics which come from the medical area, the access area, and or the commercial area. In summary, the patient flow helps to quantify the patients in each of the different disease states, whereas the patient journey helps to understand which steps a patient goes through and which stakeholders will make which particular decisions on the way to the gold standard therapy. Stakeholders are then identified, and their specific beliefs, which will either bring the patient to the gold standard therapy or will not do so, will then form the basis of a cross-functional action plan.